All right. So, if you recall, last week on Monday, we really truly kind of, laid the groundwork for defects. So for problems or defects in the mechanisms of our immune defense. So we kind of talked about what would happen in the perfect world under perfect circumstances last week in terms of the immune system, how the immune system is supposed to act. So that we could truly inform and make better our conversation this morning regarding infection. So, when the immune system does not work or when it does not work properly. So today is infection and defects and mechanisms of defense. And then also at the end, a little bit, we'll talk about the relationship and the sort of the collaboration, if you will, between stress and disease and, illness. I don't think I need to tell you that as college students, right? That stress actually can impact your immune system. So we'll talk a little bit about that at the end as well. Okay, so here's your objectives for you. So really, if you ask me, the true essence of pathophysiology is obviously when things go wrong. So you really, again, can't talk about pathophysiology and think about when things are going wrong for our patients without looking at when things start to go wrong with their immune function. As soon as you get into clinical in a couple of weeks, right, you will take care of patients that either are coming in because of some sort of infection, or unfortunately they have acquired an infection while they were hospitalized, right? Unfortunately, that is way too common. So this is going to apply to every patient, to every situation, to every clinical experience you have for the rest of your lives until you retire as a nurse. This is truly a very sort of relevant, important lecture. So that being said, let's talk a little bit about this relationship between microorganisms, so the bad guys, and us as humans, or our patients as humans. Unfortunately, we know that sometimes infectious agents can inhibit or can escape those 3 lines of defense that we talked about last week. And for a lot of microorganisms, unfortunately, the human body is a very hospitable place to grow and to flourish and to do quite well for themselves. But that's not always the case. There can be a mutual relationship between the human body and microorganisms. And the example that I can sort of give you for that is the normal flora, the normal bacteria, specifically found like in our gut, in our GI system. Sometimes that can be a perfectly fine relationship that actually ends up sort of protecting the GI system. However, we know that the relationship there can be breached if the immune system's down, if the immune system is compromised, or if these bugs, these microorganisms that are found normally, like I said, in our GI tract, can leave their normal sites and kind of, migrate to other places and cause infection elsewhere within the body. So it's not always a good relationship. It could be good or bad, but sometimes it's perfectly fine. A lot of these normal flora microorganisms are also the microorganisms that cause problems like in opportunistic infections. What do I mean by an opportunistic infection? What do I mean by that? Anyone know? Did I see a hand? Yeah?
Like when the body is weak enough, your immune system can normally fight it off or keep it under control.
Right.
And then when it becomes weak,
Perfect. So, so normally your body can kind of keep it in check, keep it in balance, and if your immune system's down or you're immunocompromised, sometimes that bacteria that stays in check can sort of overgrow and take an opportunity, thus the name opportunistic microorganisms, to sort of flourish and cause problems. So these types of microorganisms normally would not cause disease in a normal, healthy person, but they can certainly seize the opportunity, provided by a person's decreased immune system or inflammatory responses. Anyone know a really good example of that, of an opportunistic infection? Yeah. Pneumonia and AIDS patients. Perfect. Very good. And we're going to talk about HIV and AIDS a little bit more specifically later on in the morning. Very good. Very good. Another example I could give you would be like C. diff. Clostridium difficile in our GI system. We'll talk a little bit more about that as well. And also Candida albicans, so like a yeast infection, that's also a really good example of an opportunistic microorganism. Those things are kind of all 3 things that we just sort of mentioned. They're always sort of there, but it's when your immune system is down that they can sort of overgrow and flourish and actually cause problems. Most of the time they're there and they cause no problems, if that makes sense. But yeah, so what also could be, let's talk a little bit about this example of C. diff. So what this is a really sort of painful GI situation in which Clostridium difficile, a normal bacteria that's in our gut, in our GI system, sort of overgrows, causes really horrific sort of abdominal pain and cramping, really bad diarrhea, and it can cause issues with like electrolyte imbalance and dehydration and things like that because of the profound sort of volume of diarrhea that happens in it. It's, our human bowels are normally colonized by these microorganisms. What might be a reason why it would have a chance to sort of overgrow and cause problems? Yeah. Antibiotics. Hard-hitting, broad-spectrum, big-time antibiotics can often wipe out the good bacteria in our GI system and allow for that C. diff to sort of overgrow and proliferate. Good. Very good. Also, just sort of interestingly, microorganisms that are in our bowel oftentimes are good. They do good things. They sort of protect the GI system. They get nutrients from the food that we eat, and they're able to sort of produce enzymes that facilitate digestion. They sort of have, again, some of these other microorganisms have antibacterial factors that prevent overgrowth of that C. diff or other types of bad bacteria, and they can sort of produce usable metabolites or sort of help with like vitamin K, vitamin B sort of metabolism and things like that. So you can imagine then if those are sort of beaten down by, let's say, heavy-hitting antibiotics, how the absence of those things can really cause a bad environment on top of the C. diff sort of overproliferation. And you'll see that a lot. You may not have heard of it yet, but I promise you within, the end of your clinical this semester, you will hear or know something about that with your patients. Okay, so let's move on then and talk a little bit about factors for infection. Okay, so what kinds of things, let's talk a little bit about some terminology or some vocabulary. What kinds of things may impact the sort of rate of infection or the strength of the infection in our patients when we're talking about them at the bedside? So the first term of vocabulary word we kind of need to talk about here is communicability. So obviously that's pretty sort of, self-explanatory. The ability to spread from one person to another. We know that depending on which type of disease or pathogen you're talking about, some are spread very easily, some are not very communicable. So example here is measles and pertussis, they're sort of airborne, they're very communicable, so they have a high communicability. As opposed to like the HIV virus, it has a lower communicability. You can't just, get it from the air or get it by sitting next to someone. So that's kind of the example of communicability. Immunogenicity. What do you think about that? That's actually the ability of a pathogen to actually induce that immune response. And we talked a little bit about that last week, it's sort of that sort of term, immunogen. And so again, it's the ability of the pathogen to actually not just get into the host or get into the body, but actually induce a response from the immune system. And that's certainly something that you can sort of think about with different types of pathogens as well. And what's interesting as we continue to sort of talk about these different terms and these vocabulary words, true pathogens truly they're pretty smart, unfortunately. They're pretty smart and tricky. And they really have devised means to circumvent our normal immune system, right? Those normal defensive barriers that we've talked about. And so as we move through the rest of these terms, sort of be thinking about that. How would they sort of circumvent? How would these pathogens sort of get around some of these normal protective mechanisms that we talked about and spent so much time talking about last week? So several factors influence the microorganisms' sort of capacity, if you will, to invade and cause disease, and that's what these terms are. So let's talk a little bit about some more. Okay, infectivity. So this is kind of maybe the less specific version of immunogenicity. This is just the ability of the pathogen to invade and multiply in the host. So to get in and to start to multiply. So it involves sort of those things like the ability for these pathogens to sort of attach to cell surfaces within the body, release their own little damaging enzymes, escape phagocytosis, and spread through the body through oftentimes the circulatory system. So through lymph fluid, through blood, things like that. So the ability to sort of invade and infect. Okay, now again, a lot of these terms are very similar, but pathogenicity is even different than those other previous two. So this is not the ability to get in and invade and multiply like infectivity, and it's not the immunogenicity in that it sort of elicits an immune response. This is the true ability of an agent to actually produce the disorder, the disease. Okay, so there's some sort of nuances here between the different definitions. And so the success of a pathogen's pathogenicity really does depend on some other of those terms. So it depends on the communicability, so how able it is to sort of spread from person to person. It is dependent on its infectivity. And it also can sort of depend on the extent of tissue damage or cellular damage done to that host, to that tissue. And then it's also dependent on a term called virulence, which we're about to talk about in just a second. But really the way you can think about pathogenicity is that it's actually able to produce the actual disease. So it actually makes the person ill. The other ones that we talked about didn't necessarily mention the person being ill. It just talked about the person being invaded or the immune system being engaged. This is what actually would make the person sick. Mechanism of action, I think that's pretty self-explanatory. Portal of entry, also kind of self-explanatory. Is it something that's airborne? Is it, contagious via direct inhalation? Is it something that happens more through, ingestion through the GI tract? Is it sort of vector-borne, like bite of an animal or bite of an insect, something like that? That's what those terms are sort of getting at. Okay, here's another one, very similar, but again, nuanced. Toxigenicity. So this is the ability to produce, of a microorganism to produce some sort of soluble toxin, or sometimes you'll hear it referred to as endotoxin, which are factors that greatly influence the pathogen's degree of virulence. So the toxigenicity of a microorganism really gets at how strong is it, how sick does it make the person once it actually gets in and starts to invade and starts to multiply. Sort of what kind of damage does it do is sort of how you can think about toxigenicity. And then we've talked about this term virulence. Maybe I should put that sort of at the beginning of these terms because we kind of talk about it throughout. Virulence. So this is the capacity of a pathogen to cause severe disease. So, for example, the measles virus is a very low virulence, right? Just because someone gets measles doesn't mean that they're going to be extremely ill. It doesn't mean that it's lethal. It's low virulence. As opposed to someone like getting infected with rabies, obviously that's a very high virulence. So hopefully that makes sort of a clear delineation for you regarding that term and that definition. Okay. Any questions about those terms? Again, kind of self-explanatory, but kind of wanted to touch on them just because it's going to make more sense to kind of hash out those terms as we talk about items for the rest of the morning. Any questions about those vocab, so to speak? Okay, good. So, let's now talk here for a little bit this morning regarding the different types or the different classes of infectious microorganisms that I guarantee you will see in your patients. And again, it's kind of a good time to start talking about this content as you start to sort of move out of Batty and into the hospital, because guarantee you are going to see this stuff, and hopefully it'll make a little bit more sense to you, or at least have a little bit more of a background. So you see a whole list here on the screen, but we're going to really focus on the top 4 today. So we're going to talk about viral infections, bacterial infections, fungal infections, and then protozoa, or sort of like parasites. So these are the 4 types that we're really going to focus on for today. The rest of them you don't really need to focus on for the purposes of this class. Okay, so bacteria, your friend and mine. Again, probably one of the biggest reasons that we'll see infections and issues with our patients in the hospital is bacterial infections. Bacteria are prokaryotes, so they are sort of a simpler makeup. Their survival and their growth definitely does depend on the host's defense, or sort of the strength of the host defense. And obviously the bacteria's ability to sort of resist those defenses of the patient. One thing that's sort of good for the bacteria and bad for us is that a lot of bacteria have a pretty strong, hard, if you want to think of it that way, surface coat that really does protect the bacteria from phagocytosis, so it can protect itself from sort of getting eaten by our phagocytes and our immune system within the body. Bacteria also, and this is sort of a specific thing just for bacteria, produce some of those toxins that we talked about when we referred to toxigenicity. Bacteria are the microorganisms that really do produce these things called exotoxins and endotoxins. And these are the things that really sort of damage and injure cells and the tissues within our patient's body. So endotoxins are found oftentimes in the cell walls. And they are released during lysis or destruction of the bacteria. So Why would we be concerned about that, especially like in our patients? If the bacteria itself that's invaded our patient's body have these endotoxins in their cell walls, specifically I'll tell you in gram-negative bacteria is where you see a lot of these endotoxins. And these endotoxins are released during lysis or breakdown or destruction of bacterial cell walls. Why would we be so concerned about this? Think clinically. If a bacteria sort of releases toxins when it's getting broken down or when it's getting degraded, what might we be concerned about in clinical world, so to speak? What do you think? What do you think? Yeah, take a stab.
Giving antibiotics.
Perfect. Perfect. So if you're giving an antibiotic to sort of counteract this bacteria in your patient's body, you actually may see complications by use of antibiotics, or even their condition or their infection for a short period of time get actually worse because of the use of antibiotic, because when you broke down those bacteria, they released all their toxins into the system. That is certainly a very sort of relevant, real problem with the use of antibiotics, especially, as I mentioned, in gram-negative bacteria. So very, very good. And then the other type of toxin, so endotoxins are the ones we just talked about that are sort of found in the cell wall of bacteria. Then we have exotoxins, and these are oftentimes released during bacterial growth. So as the bacteria is growing and proliferating within the body, they're actually reducing toxins as well that are injuring and damaging the cells and the tissues as well. So just kind of some things to be thinking about, that it's not just a straightforward infection sometimes. It's not just that you're fighting the bacteria, you're also fighting the toxins that the bacteria sort of bestows with it as well. Also, the endotoxins that we talked about previously, they're also quite often what sort of elicits a fever response, which actually, that's what makes the patient sort of febrile with the fever, is the endotoxins. They activate the inflammatory process and produce fever quite often in our patients. Okay. Something that I wanted to just briefly touch on this sort of conversation about bacteria is also this issue of bacteremia or septicemia. Again, you will hear about this all the time in your clinical experiences. What's bacteremia? Anyone know? So think about it. Obviously bacteria, and then emia. What does that sort of root always mean if it's emia? In the blood. So bacteria in the blood, right? And then if it gets, so presence of bacteria in the blood. Then if it gets so bad and it really starts to proliferate and flourish, you move sort of from a bacteremic condition to a septicemic, which means that the bacteria is actually growing and proliferating and getting worse in the blood. So that's the difference between the term bacteremia and septicemia, and you will hear both. You will definitely hear both in your travels clinically. So this happens really because of a result of a failure of the body's mechanisms of defense that we talked about last week. Oftentimes this will be again seen in a lot of gram-negative bacteria. And toxins that are released from these gram-negative bacteria in the blood cause the release of vasoactive peptides and cytokines that produce widespread vasodilation. Now, why would we be concerned? So we're already worried about, now we know that the patient has a bacterial infection, it's growing and proliferating in the blood, so we know that once it's in the circulatory system, it can get everywhere in the body because it can travel very easily in the circulatory system. Now we have these endotoxins that are producing sort of widespread vasodilation. What are we so concerned about now? We're just kind of go one step forward into sort of worse conditions. Why are we be so worried about vasodilation in this particular patient? What do you think? Why are we concerned about vasodilation? Yeah, take a stab. Okay, well, we said the infection probably is starting to spread all over the body because it's in the circulatory system. I like how you're thinking. Yeah. Exactly. Now we're starting to talk about hemodynamic issues, right? So we know that we talked about this before when we talked about some of these types of issues where, we have this good sort of tone of our vessels and we've got normal volume of blood circulating in that vessel. And now we have vasodilation where the vessel is just going to sort of dilate and sort of relax out, and it's all floppy and big and sort of stretched out. What happens to that blood, that volume of blood that was inside that vessel? it doesn't change. You're not losing blood, but sort of relatively speaking, you have less volume in the tank because the tank has now gotten bigger, right? So you have profound hypotension. So now we're talking about a blood pressure now of, you know, rock bottom. So, I mean, I've seen septic patients with, systolic blood pressures in the 70s. I mean, honestly. So now we're worried about circulation, right? We're worried about adequate blood flow, adequate oxygen, adequate nutrients getting to the tissues because of this profound hypotension, this profound vasodilation that's occurring, all because of these wicked little toxins that the bacteria has sort of released into the system and into the blood. Does that make sense? So does it show how these bacterial infections can sort of compound themselves and get more and more complicated? And it's not just a true infection, in this little area in this tissue. Now we're talking about this widespread systemic infection that's now causing hemodynamic changes as well. So lack of blood flow, maybe to the heart, maybe to the brain, issues like that really make these people sick, sick, sick. These are the kind of patients, these bacterial infection, bacteremia, septicemia patients are the kind of patients that you see really sick in the ICU kind of patients. So this is not something that you just sort of take lightly. Oh, it's a bacterial infection, you just give an antibiotic. No, these people are really sick. These are the patients who are, pretty high mortality risk, actually. So again, just wanted to make that sort of clear to you clinically and sort of bring it to life clinically. So the biggest problem or the biggest risk of septicemia is oftentimes this profound vasodilation that causes the hypotension and lack of blood flow to all of the sort of important organs in the body. Hope that's clear to you. Okay, any questions about bacteria before we move on to the next? Yeah. Mm-hmm. Sure. Yeah. Yeah. Okay, so yes, you would have to do some fluid replacement because just to try to bump up their volume a little bit, but the issue is that because it's not truly a fluid deficit problem, you've got to do more almost like vasoactive kind of mechanism. So you actually have to give them drugs to increase, give them IV drips to increase the tone of their vessels. And you'll talk about that more when you get into sort of more critical care and that sort of stuff. But you actually have to, increase their vessel tone to be able to sort of counteract that vasodilation. So fluids would help, yes, but it's not going to fix the problem. You got to fix the tone of the vessel. Yeah, good question. All right. So viruses, next bad guy. Okay, so viruses are a little bit different than bacteria. Viruses, I think we actually kind of briefly mentioned this maybe last week or the week before, they actually cannot replicate and proliferate outside of the cell. They have to be in the cell. So they have to take over the genetic and metabolic actions of the host cells and use them for their own. So they use their own stuff, or the cell's own stuff, for their own survival and sort of replication. And so that's the key reason for why viruses can be so evil and so tricky, because they really do sort of take over the genetic and metabolic action of our own cells and use it for their own, because they can't do it on their own. Also, they're very sort of evil because they can mutate within the host cells. So and so they can do all these proliferation and mutation within our cells. And when they're hiding in our cells in our body, they're really not available to the immune mechanisms and all the inflammatory mechanisms that we talked about last week. So that's what makes them so tricky and so evil, is because they hide within our own cells and they sort of evade our own mechanisms to sort of counteract them. And that's another reason you see here on the screen, they're not available to the antibodies in our circulation because they're hiding in the cells. So that's one reason why they can be pretty tricky to sort of control and treat, and why like antibiotics and things like that aren't helpful on viruses. However, there is good news to this sort of tricky evilness of theirs. They must eventually spread. They have to be able to sort of spread it all throughout the body. They have to eventually be able to spread from cell to cell. While they're jumping from cell to cell or trying to spread from cell to cell, our immune response can eventually sort of recognize them and identify them and start to create a response to them. So that's why you oftentimes will hear that viruses are self-limiting, right? We know that you just kind of have to let a virus run its course as opposed to like a bacterial infection where you have to treat it with an antibiotic. Viruses oftentimes will just sort of run their course and be self-limiting because eventually they have to get out of those cells to spread. And once they sort of step out the front door of those cells and out into the open, our immune system can grab them. But it just takes a while because they hide in our cells for so long. But yeah, the good news is they have a pretty short lifespan outside of the cell. And again, the reason that they have to sort of move outside of the cell is to spread from place to place. So eventually our immune system will catch them. It just takes a while. And that's why we say viruses are self-limiting. You just have to let it run its course. All right. Yeah, and also sort of interestingly, regarding the sort of structure of viruses, they don't possess any metabolic organelles. They don't possess, any of the sort of organelles that would be needed to metabolically proliferate and spread. And, that's why they have to use ours, and that's why they hide in those cells. So hopefully that kind of makes sense to you. Any questions about sort of the mechanism of how viruses work and how viruses jump from cell to cell? Okay. A couple of terms that we do need to mention when talking about viruses are antigenic variations. So viruses are pretty smart. They're pretty tricky. And let's talk a little bit about some of these terms here to kind of illustrate why. So antigenic shift is basically a term that sort of states that viruses can sort of undergo mutations in their key surface antigen, which allows them to create sort of new strains at sort of the drop of a hat. So that's one way that they can kind of evade sort of our immune mechanisms and our immune defenses is they can sort of change. They can mutate within the cells pretty quickly, relatively speaking. Anyone know a sort of a good example of a virus that can change and mutate over time? Flu virus. Perfect. That's why every single flu, cold and flu season, we have to get vaccinated again, get our flu vaccine again, because the vaccine the flu, the highest strain from last year has mutated, and it's a totally different bug now, and we have to get a new vaccine for it because every year it changes, every year it mutates, and you're not covered anymore because it's a completely different bug. Good, very, very good. And the term antigenic shift is kind of similar, but let's talk a little bit about that sort of definition. So, antigenic shift, yeah. Drift, I'm sorry, first one. Sorry, I apologize. I got ahead of myself. That was antigenic drift. So to be clear, the issue of the flu vaccine changing and mutating from season to season, that is an antigenic drift. I apologize. It rhymes and I get ahead of myself. Okay, now to be clear, antigenic shift is similar but a little bit different. So this is major changes in the antigenicity that occurs from sort of recombination of a couple of different kind of viruses together. So a brand new virus is made by sort of two viruses forming. And this is oftentimes, this is the type of shift that causes these worldwide sort of pandemics, these viral pandemics. An example that I can give you is the type of antigenic shift that would sort of combine two viruses that allows for viruses to jump, to actually make the leap from animals to humans. And can anyone think of an example of that, of an antigenic shift? Yeah. Oh, very good. Originally HIV from what kind of animal to humans? It was monkeys. Yeah. It was. I know. I can't think of the exact time. But you're right. That's exactly. Originally, that occurred because of an antigenic shift. Good. How about, and that was, we don't know exactly when that happened, but we really started seeing that come to life like in the early 80s and things like that. How about more recently? Yeah.
The swine flu.
Swine flu, avian flu, those types of things. Perfect. Where that because of a different sort of recombination of genetic sort of antigenicity of a virus can jump from one type of species to another. Perfect example being avian or swine flu. Very, very good. You're getting it. You understand the concept. Very good. So also what I hope you truly do understand and that you sort of get from this slide is that viruses are very smart. They can be very hard to control. Eventually, they can sort of run themselves into the ground and can be self-limiting because of their need to sort of jump outside of the cells, but for a while they can be pretty hard and pretty tricky to control. And again, that's one of the reasons, and pretty complicated. And so when we talk a little bit about HIV in a little bit, it's again, sort of understandable why it's kind of hard to control and why it's been so hard to sort of cure and treat. So anyway, wanted to make that clear to you about viruses. Any questions about viral infections before we move on? All right, moving on to fungus. Okay, so fungus are a little bit more sophisticated than like bacteria. They are eukaryotes. They are large microorganisms that have really thick, rigid cell walls. So why do we care? Who cares clinically that fungi have thick, rigid cell walls? I mean, we're not biologists. Yeah. Exactly. It's harder to treat them. It's harder to destroy them. Exactly. So clinically speaking, for our patients, it's much harder to sort of get a fungal infection sort of under control. Good. Very good. They can exist as sort of single-celled yeast, or they can be more multi-celled molds, or they can be kind of a combination of both. We know that fungus reproduce by simple division or budding. And again, we're worried about this in terms of its pathogenicity of fungal infections, okay? The fact that fungal infections can truly very sophisticatedly adapt to their host environment, so they can sort of withstand wide temperature variations. They can digest keratin, so they start to kind of digest some of the, products of like skin and nails and things like that. And they can also, unfortunately, do really well in low oxygen environments. So they don't need a ton of circulation. They don't need a ton of blood flow to be able to still grow and do very well for themselves. So again, that's what makes them a little bit harder to sort of get at and control, because they don't need a lot. They can do quite well without very much. They're also really good at suppressing our immune defenses. The good news is, however, is that they can eventually usually be controlled by our phagocytes, and our T lymphocytes are usually the two big sort of immune cells that can really get at and sort of impact the growth and division of fungus. Yeah, question?
So it says resist penicillin and cephalosporins.
Mm-hmm.
Those are antibiotics.
Yeah.
So what's that about?
Well, just because...
Some antibiotics work?
Well, sometimes they do, and the issue is that sometimes they can work depending on what type of fungal infection it is. And again, what you really want to get at and what you really want to understand here is that because of their thick cell walls, it's hard to really get at them at all. So sometimes they'll try it, but usually not very successfully because of the structure of the actual cells themselves. Good question. Okay. So yeah, so these things, like the ability to sort of adapt to their host environment, is really good for them and bad for us, or bad for our patients, because of how well they can do without a lot of sort of blood flow and oxygen and nutrients and things like that. Okay, so interestingly, when we think of fungal infections, at least I usually think of sort of superficial irritations, right? Skin, nail fungus, skin fungal infections, things like that. However, they can truly range from a very superficial infection, like I just mentioned, all the way to very, very complicated, very serious, situations that make our patients very sick. And oftentimes these fungal infections that are really deep, like into tissue, into organs, into the bloodstream, things like that, are usually in association with other diseases or other conditions that sort of, someone's immune system is down and they're sort of almost like an opportunistic kind of infection. Again, seeing it a lot of times in people who have immunosuppression or, have a decreased immune function. So again, what are some types of patients that are immunosuppressed who you might see these really sort of strange, deep tissue, deep organ fungal infections on? What are some patient populations that are immunosuppressed where you might see some of these fungal infections? What do you think? What's that? Oncology, why? Why would an oncology patient or a cancer patient be immunosuppressed? Do you know? Chemo, great. Chemo wipes out the bad cells, but also the good cells of our immune system as well. Good. And there was another hand in the back. Yeah. Transplant patients. Why are transplant patients immunosuppressed? Right. Transplant patients are on, for the rest of their life after an organ transplant, transplant patients are on immunosuppressants for the rest of their lives to make sure that their own immune system doesn't attack that new sort of foreign organ. So they are very immunosuppressed for the rest of their life. So these are also high-risk types of infections for all of those patient populations that you talked about. Very good. So fungi can invade the skin, hair, nails. These are known sort of as your dermatophytes. So you can sort of see here the different diseases that they produce depending on which area of the body that they're sort of wreaking havoc. So tinea capitis is the scalp. You see athlete's foot there, tinea pedis. Tinea curis is in the groin. Oftentimes, again, clinically speaking, I will tell you this, when you start to have more experience in the clinical setting, oftentimes fungal, like dermatophytes, these fungi that invade skin, hair, and nails, are going to really sort of proliferate and grow in dark, warm, moist environments. So you honestly have to be very careful, like when doing a skin assessment or when bathing a patient or when sort of considering that sort of aspect of your patient, to really, look in skin folds. Look in the groin. Look in if a person's pretty overweight and they've got a lot of skin folds, actually looking, pulling the skin folds apart and looking. I remember whenever I was in nursing school and kind of doing my first clinical experience in a nursing home, my clinical instructor was really telling me about the importance of, like, in older women, I'm not trying to be insensitive, but in older women really like lifting up their breasts, just make sure the skin is sort of not broken down, because you can really have bad skin breakdown and bad fungal infections in skin fold areas that you don't even think about looking. You don't even go there. You don't even see it. So these are the kind of fungal infections that you see a lot in skin folds, so to speak. And then, like the deep, more fungal infection, systemic fungal infections involving internal organs, as I mentioned, can certainly be very life-threatening and are commonly opportunistic. Another example, we talked about some of the other ones already. Another example of a good example of an opportunistic fungal infection is Candida albicans. Anyone know another name for that you might be actually more familiar with? Thrush. Very good. Thrush. So another name for Candida albicans is thrush. Again, this is the kind of fungus that is, or the presence of this, shall I say, is normal to find in the mouth, in the GI tract, in women in the sort of the vaginal tract, and any change in pH or the use of antibiotics can actually destroy the bacteria that normally inhibit the overgrowth of this type of fungus. And so it allows for sort of growth and permits rapid proliferation and growth of this type of fungus. So let me give you an example here. Here's a really good picture of thrush in the mouth. So you're kind of looking at the back of the mouth, the uvula and the tonsils. This is a really great picture of thrush. Now, this is not normal, right? It's not normal to have thrush present, overgrowth of Candida albicans in the mouth. Again, it's normally there, but it sort of stays at bay. So if you see this, let's give you a clinical picture. Someone comes into the ER saying, over the last, couple of weeks or so, I've just noticed this weird sort of white, cauliflowery looking stuff in the inside of my mouth. I can't get it to go away. I try to scrape it. I try to brush it with my toothbrush. Can't get it to go away. If they're coming in with no background history of immunosuppression or any type of disease that would sort of create this situation, what are your red flags? What are you immediately concerned about with this patient? They're telling you, they're not a transplant patient. They're not on immunosuppressant drugs. They're not an oncology patient. They're not on chemo. Is this normal for someone to show up with this? So what are we starting to be concerned about here? What do you think, clinically speaking? Yeah. Yeah, maybe there's some sort of new immunosuppression going on. Right, exactly. Maybe, and so then we're going to start doing, blood tests to look at their white counts, their CD4 counts, start looking at sort of their other sort of immune cell counts, because it's not normal for someone to come in with these sort of strange infections that would normally be sort of kept at bay. It's telling you that something else is going on with the immune system, and that's certainly the case with like a thrush infection like this. Very good. Excellent. So again, just to be clear, some fungi are part of our normal flora, and they really only truly become pathologic when our immunity is compromised. And so that would certainly be the case of a situation with someone having thrush in their mouth or something like that. Is that clear? Does that make sense? That is not something you would normally see, and if you do, it should send up some red flags in terms of immunity. Okay. All right. Great. All right. Yeah, I actually had a couple of patients like that come into the ER one time, and they're like, oh no, I'm not on any, and they don't know, they don't understand like what this sort of looks like or what this means in terms of their immunity. No, I'm not on any immune suppressants. No, I'm totally healthy. I'm totally normal, and I immediately want to know their backstory. What's going on? Because there's something going on with their immune system if they show up with these sort of weird fungal infections that we normally wouldn't get. So, okay. Next one and last one, parasites. So unfortunately, we know that parasites are symbiotic. And whenever I say symbiotic, I mean that the parasite benefits at the expense of the individual or at the expense of the host, right? They're unicellular protozoa all the way to sort of large worms. Some examples would be like a pinworm, tapeworm, those types of things that you hear about. So protozoa would include things like malaria and amoebas. And because of that, because of the situation in which parasites sort of grow and proliferate, you will more commonly see these in more developing countries than, say, here in the United States. Oftentimes they are waterborne or foodborne parasites that get into the host that way. So again, we don't see it as much here in the United States because the spread from human to human is usually through vectors or through contaminated water or food. So again, those situations luckily are just not as present in first world countries, so you'll see them more in developing countries. Parasites are usually ingested quite frequently, so they're eaten or drank. And what's interesting here with parasites, again, because it's symbiotic, not only does the parasite sort of proliferate because of it sort of taking over the host, but it also can do a lot of tissue damage. So tissue damage is usually secondary to infestation itself, with the toxin actually causing more of the damage or causing more of sort of an inflammatory response from our immune system than the actual parasite itself. So it's oftentimes the toxins from the parasite that produce more harm than the parasite itself. Anyone know a good example of a parasite? I mean, I sort of gave some here, but can you think of any others or can think of a situation? I have a good one for you. Several years ago, I did some nursing field work in Honduras, and one of the days that we were in the town that we were working in, we did sort of like a pediatric clinic. And so a lot of the moms through the sort of small town or the village that we were working in were bringing in their kids for, all kinds of different kinds of checks and physicals and things like that. And this one mom brought in her baby. It was definitely a baby. I mean, it was like under a year, still wearing a diaper kind of age little boy, coming in because he had this really bad diaper rash. That he'd been sort of really having a lot of sort of pain and itching, and he'd been scratching out a lot lately. And it was sort of starting to actually, because of the scratching and the irritation, was really starting to sort of break down the area, specifically sort of around the rectal area. So we took the diaper off and kind of started looking, and the nurse practitioner that I was working with that lived there in the village, as soon as she sort of took off the diaper, she had seen it so many times, she knew what it was. It was not just a pure diaper rash, it was actually a situation of a pinworm. Anyone know how pinworms work or what the sort of clinical presentation of pinworms are? I didn't either, I learned that day. So what happens is pinworms have eggs that are usually in water. So in this case, it was in the drinking water of this village that this little boy lived in. So the eggs actually passed into his GI tract. And then what happens is the eggs themselves hatch in sort of the small intestines of the host. And as they get bigger, the larvae sort of kind of migrate and move into more of the large intestine and into the colon. And there they can live there as parasites for a super long time. Now, sometimes you don't know it, and sometimes they wreak havoc. So sometimes because they're living in your, colon, they're living in your GI tract, they cause a lot of issues with sort of nutrient absorption, water absorption, causes a lot of issues with, dehydration because of diarrhea and, a lot of weight loss and things like that. But guess it didn't really cause that big of an issue with this little boy because the mom was not coming in complaining of any of those things. He did not have diarrhea. He was eating fine. He wasn't losing weight. She was just purely coming in because of this irritation around his rectal area. So anyway, then what happens after the larvae sort of sit and sort of live in the large intestine or the colon for a while? Eventually, the female pinworms, the female parasite, want to lay their eggs. And so what happens is, and this is the part that I did not know until that day in Honduras, they come out of the large intestine, they crawl out of the rectum, and lay their eggs like around the outside rectal area, and then go back in. And so what this little boy was experiencing was the itching and the skin irritation from the eggs underneath his skin around that rectal area. So again, the pinworms actually come out of the rectum, out of the GI system, lay their eggs, and go back in to the GI system. And that's what this little boy was experiencing. So again, and it was sort of the eggs and the toxins that was actually producing the irritation and the tissue damage around that rectal area, not the parasite itself. So whenever and it itches, I mean, it's extreme itching, really, really intense itching. And that's what this little boy was having because of this parasite. So anytime I need a clinical sort of picture of parasite, I always think of that little boy in Honduras. Poor little guy. So any questions about parasites? Yeah. There's actually anti-parasitic medication that you have to give. Yeah. No, quite oftentimes it's a oral medication that you have to take. Yeah. Mm-hmm. Well, you mean if you take the medication? Yeah. But this is something that can go on for months and months and not even know it. Yeah. One more question.
Are there any long-term damage?
Luckily, no. Luckily not. Yeah. Luckily, that is not the case usually with this particular situation. Oftentimes, the damage that's done or the problems that are caused by parasites are issues with causing dehydration and that kind of stuff. That's usually the biggest problem with weight loss, electrolyte imbalance, that kind of stuff. Yeah. Any questions about other questions before we move on? You'll never forget parasite now, right? Okay. So now that we've talked about some of these infections, some of these infectious processes, let's talk a little bit about the clinical manifestations. So again, it's so important to not only understand the infection itself, but then what we're looking for, what we might see in our patients. So obviously we talked, as we moved through each one of these different types of pathogens, we talked about how clinical manifestations can certainly vary depending on the pathogen that you're talking about. Either directly by the pathogen, the pathogen itself causes clinical manifestations, or more indirectly caused by its products. Like in the case that I just told you of, it was the eggs that was actually causing the problem, not the actual pinworm in that situation just mentioned. One of the big, clear sort of, classic manifestations of really a lot of different types of infections, no matter if it's viral, bacterial, whatever, is fever. And oftentimes, we think as fever as a bad thing. But really, clinically speaking and sort of physiologically speaking, fever is a really beneficial thing. What's interesting and sort of why it works is that, or shall I say why it's beneficial, and we talked about this last week, is that it really does increase metabolism. So it increases our ability to sort of fight and phagocytize a lot of these different types of pathogens. And it just causes usually a bad environment for pathogenic growth. So if it's too hot and if it's too warm of an environment, oftentimes pathogens don't like that. And then I just kind of put a couple of things here on the screen for you. But what I really want you to understand is the whole fact that it sort of resets the hypothalamus. It resets, and we'll talk about this later when we talk about neuro, but it sort of resets the hypothalamus, or the thermostat, so to speak, that our normal temperature is sort of set higher, and it actually helps phagocytize and help break down that bacteria or whatever it may be a lot more efficiently. Okay, but again, what I really want to drive home here is that no matter what type of pathogen, we need to know what to clinically expect to see in our patients. And we talked a little bit about that as we were moving through each one of those pathogens. Okay. All right. Now, this is where we really start to bring what we talked about last week and what we talked about this morning in terms of the different types of pathogens together. We're starting now to talk about the countermeasures against some of these infectious microorganisms. So, depending on what our countermeasures are, depending on, shall I say, what our infectious microorganisms are, you really do have to think about the sort of the issues that we talked about last week of, but wait, what about our immune system? What about those inflammatory responses, that second line of defense, that third line of defense that we talked about last week? Where are they? Well, it's either because this infection has sort of evaded those mechanisms, or the mechanisms aren't good enough or strong enough, and so we need some help. We need some medication, so to speak, some drugs. So let's talk about, so it's not, I don't want to say it's in spite of those defenses that we talked about last week. It's sort of in combination with some of those things that we talked about. So let's talk first about antimicrobials. So these are the, antibiotics. And you can either sort of categorize your antibiotics in sort of bactericidal or bacteriostatic. Anyone know the difference? If I'm saying a medication is bactericidal, what do you think that means? It kills the bacteria. Good. So it just targets the bacteria and kills it. Just blows it up right there. Now, what about bacteriostatic? If an antibacterial is bacteriostatic, what might it do? It just inhibits growth. So why is that helpful, though? Why just stopping growth? Why is that helpful? Yeah. Exactly. Perfect. It inhibits growth enough so that then the immune system can sort of get at it. Good. Right. So that's the difference between bactericidal and bacteriostatic. And you see kind of some of the mechanisms in which those things actually work by inhibiting the function and production of the cell wall of bacteria, and some of the other things that you see there. Very good. Excellent. We'll finish this slide and then we'll take a break. So let's talk a little bit about antimicrobial resistance. So it is possible for bacteria to sort of mutate as well, undergoing some sort of genetic mutations. It is possible then, once the bacteria itself has sort of genetically mutated, to sort of inactivate or make antibiotics useless, so to speak. Why does that happen? What is sort of a situation or a environment for these bacteria in which they are able to sort of genetically mutate? Yeah.
If you're using an antibiotic and you don't follow through with your full order, or you just have a large supply, the ones that survive your initial attack are going to specialize by doing these things. And
Perfect.
when they proliferate again, now you have a whole system that aren't working.
Right.
With the drugs from that.
Right. Perfect. So initially, when you first take that antibiotic, initially the bacteria that die are sort of the weaker ones anyway, the ones that aren't maybe as smart or as tricky. And so if you just stop then, what you've done is you've killed the weaklings, but you haven't given enough time for the good, strong, smart ones to get killed yet. So now all you've left behind are the good, strong, smart ones, and now they grow and proliferate and wreak havoc, and now they're the ones initially that weren't killed by the antibiotic, and now you try to give an antibiotic, and now none of them will be killed because they're all that type of bacteria. Does that make sense? So that's why it's so important to take your full dose of antibiotics when you get them. Even if you start to feel better and even if your symptoms go away, you got to take every pill until it's gone, or else you will allow for these antibiotic resistant strains of bacteria. A great example of that is MRSA. So methicillin resistant Staphylococcus aureus. This is a really big sort of resistant bacteria that you see in the hospital. So you'll have contact with this for sure. And again, one of the reasons that it sort of even came into creation or came to fruition was because of this poor sort of compliance with antibiotics. That's perfect. Very good. Very good. So these antimicrobial resistant situation is really a major health problem in our hospitals. And one of the reasons is lack of compliance, like we just said, that you don't take your full dose of antibiotics. It allows for selective resurgence of those really strong, good microorganisms that are relatively resistant. But what's another reason why antimicrobial resistance occurs? So we said lack of compliance. What's another good one? Yeah. Overuse, right. Overprescription or overuse. Very good. Because of the same types of things, things can be sort of be exposed to that antibiotic and then get resistant to it. Very good. Excellent. And then another sort of problem with antimicrobial use is kind of what we talked about already, the fact that it can kill the good bacteria as well and allow for the bad bacteria to sort of overgrow. And that's that issue that we talked about earlier of C. diff, C. difficile. The antibiotic can actually destroy the normal flora and let C. diff sort of resurge. Good. Excellent. All right. We will stop there and take a break, and then we will pick back up with vaccines after break. Great. Thanks, guys.